So good morning, everyone. My name is Jackie. I'm a second-year Peds resident, and today I'll be presenting on a subject that is actually very near and dear to my heart. I'll be talking about those individuals who I consider to be our frontline providers, and these are the parents who take care of our children with medical complexity. And I hope that by the end of this talk, you can also appreciate just how vital they are to the care of our patients. I have no relevant financial disclosures. And my learning objectives for today are to discuss the unique challenges that this population faces, to identify the sources of support that are available, and the services that are helpful to our patients and our families, and to recognize the opportunities for healthcare systems to better support the well-being of parents with children with medical complexity. Okay, so first I think it would be helpful to go over some terminology, because if you're like me, you started off residency not really knowing what CMC stands for. So children with medical complexity, otherwise known or referred to as CMC, are clinically recognized by at least one chronic condition that typically results in high healthcare service use. So very common on our floors at Hopkins here. So these include children with cystic fibrosis, serious congenital heart defects, metabolic disorders, and interestingly, children with medical complexity are actually a subgroup of another population called children and youth with special healthcare needs. And these children are defined as kids who have or are at an increased risk for chronic physical, developmental, behavioral, or emotional conditions, and who also require health and related services of a type or amount beyond that required by children generally. And I think it's important to consider that these kids may only represent only 0.4 to 1.9% of the pediatric population, but they do account for more than 30% of the total healthcare spending in pediatrics. And because most of them actually live at home, the responsibilities of direct care and coordination rest with their parental caregivers. And so, why do we care? Well, I think it's also important to take a look at the problem. So, the study that was performed actually last year and published in the journal of Pediatrics by researchers at the University of Rochester. And they wanted to look at the mental health of our parents with children of medical complexity. And there was some shocking statistics that they found. One was that about 20% of parents with children of medical complexity reported poor or fair mental health, which is more than 5 times the proportion of children who did not have medical problems. And in addition, about 36% of parents of CMC reported not knowing where to go for help in their community when they encounter difficulties, which was also more than 2 times the proportion of parents with children without other medical problems. And particularly interesting was that this was even more true for parents of children who were Black or African American, those who did not speak English, and those who lived in lower income households. And as we all know by now, that these populations are marginalized, part of marginalized communities, and they often have difficulty accessing healthcare and community organizations. So they are particularly affected. All right. So I really like the slide because it very nicely illustrates all of the different challenges that these caregivers face on a daily basis. And as you can see, they have their own separate physical, informational, social, emotional, and practical needs that may not always align with what our healthcare system provides. And as you can imagine, a lot of these parents have very, very high levels of stress, leading to marriage tensions, financial difficulties. And a lot of the times they spend many hours per day coordinating and delivering care to these children, which can then disrupt the functioning of the overall family unit. And when I was kind of reading up on this topic, I did see a few examples. For instance, parents of children who use medical technology, whether that be those children who have trachs, who use wheelchairs or have feeding tubes, they report, even the simplest things, like interacting with their friends, or like going out into public areas they may find difficult because they may be embarrassed, may not have time to, and things like that. And there was actually a study done by Dr. Hope I'm not mispronouncing her name, but Kassam Adams, and that was at the Center for Pediatric Traumatic Stress at CHOP. It was an interesting statistic that they found, was that 1 in 6 parents of children with CMC suffer from significant post-traumatic stress symptoms. So while these parents have sometimes, make it through the initial diagnosis, initial trauma, many are often reeling from those events even years later. All right, so another stressor may be financial. And I wanted to include a direct quote from a mother. And this is a quote that I found online. And this is Miss Johnson. And she, you could read the quote yourself, really nicely illustrates the financial impact. Stems from the limits sometimes that our healthcare system has on these families. I have honestly read countless other stories. One where a family's need to pay rent and utilities left little to no money for the child's medications. Another where a family had to relocate and live with other family members during a particularly cold winter because they could not pay for their central heating because they were, spending most of their money on the child's medications and healthcare. So it is a huge stressor, and is definitely not something that can be taken lightly. I did want to include another shocking statistic that I found. There was a study that was done, and I apologize, I don't remember the exact year where it was published, but it did take a national sample of families with children of medical complexity, and they reported that about 46% of parents reported spending more than $1,000 out of pocket for medical costs per year. And another 54% reported that a family member stopped working as a result of their child's health. So it is a huge stressor. So I realized that we only, as pediatricians, we only have so much control over healthcare system costs, but there is still so much that we can do, as a unit with other individuals to better support our caregivers. And I think that the support should really involve the entire team. So here I've listed all of the, individuals that comprise the system. So advocacy groups, peer support groups, mental health providers, primary care providers, social workers, case managers, and specialty providers all play a huge role in caring for these families. And they all do their individual parts to ensure that, there's good follow-up, that the families get the support that they need. Nope. All right, so now I have a few take-home points that I think pretty much sum up my talk. One is that parents with CMC are at the highest risk for suboptimal mental health and have limited knowledge of where to find help in the community. This population may benefit from proactive screening for parental stress and efficient mechanisms for providing emotional support. And I think there are opportunities to improve parent and family wellness by embedding mental health services for parents with children of medical complexity. And these can be either in the inpatient setting, the outpatient setting. One thing that I did want to give a shout out to the complex care team at Hopkins. I personally have worked with them numerous times on very complex cases, and I think they do a tremendous job of really integrating every part of them, a child's medical care. So I think, we're beginning to see some of this play out at Hopkins. And hopefully, over the next few years, we do see some changes being made that improve the care for these patients. All right, and this is my reference slide. Thank you everyone so much. Do we have any questions?
Thank you so much, Dr. Krugliakova. This was excellent. And then if you want to, we'll go ahead and switch over to our grand round speaker. So as we are switching the slides over in different sharing, it's my pleasure to introduce Dr. Javi Eve Karkowski. She's a maternal fetal medicine doctor in New York City. She went to medical school at Icahn Mount Sinai School of Medicine and completed her residency in OB-GYN at Brigham and Women's Hospital, Mass General Hospital. She pursued fellowship in maternal fetal medicine at Montefiore Medical Center in the Bronx, where she's now the medical director of outpatient obstetrics for the institution. Dr. Karkowski is also a writer with publications in Slate, The Atlantic, and The Washington Post. Her first book, High Risk: Stories of Pregnancy, Birth, and the Unexpected, was just published and is available everywhere. She can also be reached via her website, which I will post into the chat for all to see. And without further ado, Dr. Karkowski.
Thank you so much. It's such a pleasure to be here with you. I have to admit that I feel a little bit like an ambassador from a foreign land. I come from the land of obstetrics and gynecology here in pediatrics, where I feel like you know me mostly for giving you some of your most difficult NICU patients, but I am ever grateful. But hopefully what we talk about today has to do with everything that all of us do all over medicine, and I'm hoping that we'll all connect to it. So we're going to talk today about narrative medicine, the stories we do and don't tell. So I just want to mention, and I know this is important, I mostly write about what I do, which is reproductive health, which is largely about people who identify as women. Use of inclusive language is complex and hard to do, and I think we're all always learning. My best solution so far has been to use a variety of languages. So you'll hear me talk about pregnant patients, pregnant person, but sometimes women also, because that's how most of my patients refer to themselves. And I'm always learning, so please let me know if that's been difficult for you, or for if there's a better way to do it. Another thing that I talk about a lot when I start telling patient stories is that, as all of us, we are not the center of these stories. These are not our stories to tell. And there are a lot of ethical concerns when we do medical narrative, which I've actually written a lot about. It means we have an obligation to preserve privacy, and HIPAA is sort of the lowest bar of that, and many higher bars. But I really truly think the thing that protects our patients when we tell these stories is that we have humility, that we realize that these stories are not our stories, that we are adjacent to them, but not in the center of them. And I think that humility is actually part of how you can ethically encounter these stories. Ultimately, I have come to the conclusion that we should be telling these stories. It's better to tell them than not to tell them, and maybe even to help our patients tell their own. All right, so who am I? I do maternal fetal medicine. That's high risk OB. I work in New York City. I think I work in a community pretty similar to yours. I work in a major academic medical center in some of the poorest zip codes in the United States. So I see a variety of patients. I sometimes joke that I get to do international health only 20 minutes from Manhattan. And we're a safety net hospital with over 85% of patients on public insurance. And that's sort of the community I've always felt most comfortable serving. But I am also a writer. It's taken me a long time to say that. That word used to have quotes around it, and it's taken me a long time to take those quotes away. I write for the lay press. So a lot of what I'm going to talk about is writing for the general public, which is, I think, different from a lot of medical narrative programs. It's been something I focused on from the beginning. I write a lot for Slate. I actually have a piece coming out next week. I've written for The Atlantic, The Washington Post, others, because if you're going to write, you actually have to be pretty broad-minded about where you're going to write. And my first book came out the week before the pandemic, and it's called High Risk: Stories of Pregnancy, Birth, and the Unexpected. But one reviewer called it a general critique of the American medical system from the eyes of an OBGYN doctor. And I thought that was actually more like what I was trying to achieve. So that was nice to hear. All right, so other than that, I'm just going to give you a little brief biography and pictures. I grew up actually not too far from here near Washington, D.C. in Silver Spring. I went to Yale and I went to medical school. And I do this just because I think part of what Grand Rounds achieves is the giving over of knowledge, but also it's kind of a wonderful way to meet people who have a variety of careers, see how they got here from there. And so I was going to share a little bit more of my path. So I went to a medical school and then I went straight to residency, as many of us do. This is my husband's favorite shirt. I have not found it in real life, but it says, "I'm an obstetrician husband. Yes, she's working. No, I don't know when she'll be back. Yes, we are still married. No, she's not imaginary." And I want to add a line on the butt that says, "Yes, the kids are all right. I think they're all right. I was told they're fine." I moved to Manhattan. That's the GWB. I live right near there. And I started work at Montefiore Medical Center, which, as I mentioned, serves some of the poorest communities in New York City, but also in the United States, as well as some of the richest communities in New York City and the United States. So a little bit of whiplash almost every day. This is my sweet family. I decided my husband got transferred abroad. We moved to Tel Aviv with these very tiny children who are now much bigger. In 2017, I really thought I was going to do similar work. I would work in Palestine with Bedouins or poor Arab communities. I would work in South Tel Aviv with immigrants from North Africa. None of that was able to happen based on just bureaucracy. I ended up getting a job at a Hasidic hospital, which was both sort of nothing what I expected and everything I expected. About half of my residents were Palestinian Israelis. Nobody that I worked with, most everybody I worked with was an immigrant and making their way in some way. And I have fabulous stories from my 2 years with them. This is me finally getting an ID for a hospital. I feel like the look of exhausted victory is one that anyone who has navigated bureaucracy can really relate to. We then moved back to New York City. I went back to my job at Montefiore, where I became medical director of outpatient OB, and then COVID hit. And that's sort of my brief biography. I want to overlay that with when I started writing and how that fits in with the medical career, which is frankly a very absorbing thing. I did take some writing courses in college, and I frankly just didn't think I was a very good writer. I never thought that my stuff was good enough. And then 1998 to 2007, I produced no writing. I was very, very absorbed by learning how to be a doctor, which I think is something that is both compelling and really takes all of our intellectual and emotional energy for many years in a row, at least for me. My first years in attending, I joined an online writing group, which had me start writing, but I wasn't very productive. All of a sudden in 2009, I was a first-year fellow with a toddler, and I decided at 2 o'clock in the morning that I must start a blog. And that was really when I started writing almost as a daily practice. From 2009, 2013, I wrote, but in a very modest way. I would argue that probably none of my publications hit more than 100 people. I wrote for my local medical school blog. I wrote for my own blog. I actually briefly had a Medscape blog that I am not convinced that anybody read. And then in 2013, I sent a pitch to Slate. And I want to just mention this because it took me a very, very long to pitch something, because I got very stuck in how it should be formatted, who it should go to, what would be interesting. And what was tremendously amazing is that I sort of worried over this pitch forever. And she took it, and she took the piece with very marginal edits, which means, by the way, that it was always good enough, right? It was good enough a month before. It was good enough 3 months before. It was good enough a year before. And so if I had anything to say to me back then, it would have been like, send it in. It was always good enough. From then on, I basically published every 3 to 6 months. I published in Slate, The Atlantic, The Washington Post, Daily Beast, lots of places. In 2017, I decided I wanted to write a longer form and have the ability to really explore ideas. I wrote a book proposal, I got an agent, and I got a book deal. We can talk one day about all those things. They are really hard things to do, and I know more about them than I used to, and I'm happy to share that knowledge. And I started writing my book. In 2018, my book was submitted, but not yet published. And I wrote my first, and to this day, only really, truly long form piece, which was an Atlantic piece about how Israeli abortion law is different from American law and how strange that is for an American doctor. And in 2020, my book came out. All of my book events were canceled because it came out mid-March 2020, and we found ourselves very busy. And I continue to publish to this day. I have a piece coming out in Slate next week, as I mentioned. It's very intermittent for me. And one day I still sort of want to know what I want to be when I grow up, and I'd like to write another book. So I'm starting to have little threads of ambition as we move forward. Okay, so these are just my first slate piece, the one that was always good enough, was about patients who refuse blood transfusions, which for me is a lot of why I have gray hair. This is the cover art from my Atlantic Longform piece. And then this is my book in the American cover. Actually got sold to the UK. So if you go to Canada, Australia, or New Zealand, this is the cover you'll see. And then we actually got it sold to Russia. And this is the cover, which I am assured is mostly correct in terms of my name. And at least the title. And apparently I also have a version in China. So totalitarian regimes have a real thing for my book. Wasn't my target audience, not sure why that's happening, but here we are. All right, so let's talk about writing and why we write and why I write and maybe why all of us kind of write. Okay, so I write because it turns out I sort of gotta write, right? Some of us, that's just the way we are. We see something interesting, something bothers our brains, and we wanna make it make sense. We wanna put it in context, we wanna express it to other people. But I also argue that those of us in medicine, we have the opposite problems from most people. Most people don't have something to write about. They are looking for subject matter. We are the opposite. We are sitting in the middle of waterfalls of human emotion every day. We are in the middle of a tsunami of emotional experience, sometimes at the very limits of what people should have to go through, both of joy and of pain. And we don't lack for subject matter. We lack for the ability to process, we lack for time, we lack for all sorts of things. And I think because of that, these are a lot of stories that do not get told. They often don't get told to each other, but they mostly also do not get told to the wider world. And I do think there's this feeling that we all have, which is, you know, the way you fall into conversation with other people in the medical profession versus the way that you fall into conversation with, let's say, your great aunt is different. There's a level of deep understanding we have because these stories are really hard to tell. And this is what I say a lot is that at least, and I'm sure you have similar examples, this is what pregnancy looks like in the media. 2 lines on a stick, a gender reveal party, which I just would like to say is a sex reveal party. They will reveal their gender in their due time, my friends. You're going to have to wait on that. And then beautiful newborn photos, which not coincidentally usually do not have the mother in them because we tend to not be that interested in the mother once the baby's out, which is terrible. And this is what pregnancy looked like for many people, but this is not what I see. This is not what my patients go through, and this is not what I went through. And those are the stories that we have to tell. When we don't tell those stories, we have problems. And I would argue that not telling those medical stories between ourselves to the larger public creates problems. One example is individual. People cannot process. A really good example for me is that people don't talk about miscarriage. Miscarriage is incredibly common. It's probably up to 30, even up to 50% of early pregnancy, depending on how you count. And almost everyone who goes through one thinks they're the only one, right? They think it's their fault. That's partially because we don't talk about it enough. I think we end up problems with our families. Most of the things you see or I see in the hospital is often a large part of the family's mythology, how they came to be, their origin story, and they might not know how to tell that story in a way that means that they can process it. And that often leads to trauma. And I would say that it leads to problems in your system, in your hospital. This picture is to remind me to tell you a story of how at my hospital when I was a resident, oh no, I'm sorry, I was a medical student, so I was a very unhelpful person to have around. Something happened, which doesn't happen very often, thank goodness, which is that I was on labor and delivery, and a woman went into cardiac arrest right after delivering her baby. She coded, okay? So we all know what a code is. A code is basically a bat signal that goes out to the whole hospital and says, I need help. Send me one of everybody who knows how to help me, whether it's critical care and anesthesia, and maybe the charge nurse and that code card with all the really good drugs. I need all of that, I need it right now. And we were on labor and delivery with this woman, and we started chest compressions and we started bagging. We started doing all the right things, and we waited for our help. And 1 minute passed, nobody came. And 2 minutes passed, and nobody came. These are excruciating minutes, as you can imagine. And the 3rd minute passed, and finally we hear in the distance, thump, thump, thump on a faraway door. And this is my heroic entrance to the story. I run to the entrance of labor and delivery, and I let the code team in. They come in. They resuscitate. This patient was eventually okay. Why did the code team have 3 minutes where they couldn't get in? Because we had a separate door system for labor and delivery so that nobody could steal a baby. And overall, that's a good idea. I'm opposed to baby stealing, definitely a con. But nobody had thought to think that maybe we would need to be part of the hospital. That maybe somebody urgently would have to come see us, that maybe they would need to swipe their IDs and get in. And because I wasn't at that meeting and you weren't at that meeting and nobody was at that meeting who could tell that story to whoever buys our doors or buys our IDs, that story didn't get told and decisions were made that were actively dangerous because they omitted the labor and delivery story from the hospital story. And that's dangerous, right? I would argue that happens on a policy level. I'm sure you're all aware, but I'm dealing with a lot of sort of undervaluing of what pregnancy means, how hard it can be to go through, what some of the ramifications are for patients who have very preterm pregnancies or pregnancy with serious anomalies. And those mean that laws are made that feel like they are thoughtless. And part of what I do is try to tell the stories that are not simple stories, they are hard stories, so that maybe our lawmakers will understand what they're truly asking. Because when they don't, the laws they make are just frankly not as smart and not as good. Any questions so far? This is the problem with Zoom. I have no idea. You're probably all asleep, but it's okay. We're going to keep going. All right. So I'd like to make the argument that actually you're all storytellers and so am I. And the reason we are all storytellers is because everything we do in medicine from the second you started rounding on the wards is learning how to tell a story. The entire discipline of medicine is a discipline of narrative. And what do I mean by that? I mean that the first story that we learn is a story that we tell each other, that you and I tell each other on morning rounds, that our medical student presents to me as we're trying to get out of the ED. And that story has very, very strict formulaic details. So if you think about a soap note is a story. A soap note is a story of abdominal pain. Every line in that story takes you to an adventure or away from an adventure that you might otherwise go to. She has had no recent antibiotics. I'm going away from the C. diff story. She has traveled recently to the Ohio River Valley, and I need to start thinking about all of those pathogens. And so if you think about it, a soap note is actually just a story. Every line is building the story or excluding another narrative. It's a very tight form, the same way that a sonnet or a sestina is a tight form of poetry. And I would tell you that like a fairy tale or a romance novel, there are certain elements to the story that you and I build for each other that if they are not there, we get kind of twitchy. We find it an unsatisfying story. We think it's a bad story. So I will tell you, I had to learn this because as a medical student, I am used to telling stories the way my family tells them, with a surprise ending, something really shocking. And you know what your surgical resident does not enjoy is when their medical student does not lead with the ruptured appy in the ED. They would like to know that from the beginning. When I tell them, oh, she looked great, and then guess what we found in CT scan? Nobody likes that because that in medicine is a terrible, terrible story. It's very poor quality. So the stories we tell each other are formulaic, they're ritual, they're repeated endlessly. In that way, I feel like they actually, to me, always resemble a folktale. And I love, because I think we get so used to this, and because we have the same frame of reference, the same way a community around a fire might, that our storytelling is both boring and we have elements that, because we share a wealth of knowledge, make us twitchy. So if I tell you that somebody has a cough and a fever and a right lower lung opacity, and that I gave her antibiotics, that's a great story. That was the story of pneumonia, and that felt okay. We started somewhere, we went somewhere, we ended up in the right place. If we remove an element, I had the cough and the fever and the X-ray findings, but I didn't give antibiotics, that's negligence. Or if I didn't have a cough or a fever, but I gave her antibiotics anyway, that's malpractice or overtreatment. So one example is I want you to sit and listen to your body as I tell you about the 7-year-old that I did not personally see last night in the emergency room because I do not take care of 7-year-olds right now. She came in with abdominal pain and didn't want to eat, lack of appetite, nausea, fever, and her white count was elevated. We sent her for an ultrasound. They could not see her appendix. Her pain got worse over her time in the ED, so I discharged her home. How does that make you feel? If you're anything like me, you are getting twitchy in your seat. And actually, you're going to tell me to get somebody to call that patient back because she probably has an appy, or at least we need to check it out. This is the feeling I had when I came to the labor floor and somebody told me that there was a 32-week patient who had been ruptured membranes for 3 weeks. And she just got a fever, had fetal and maternal tachycardia, and they stashed her in labor and delivery room 8. And I was like, and thus, right? That is the story of choreo. That is the absolute story of chorioamnionitis. But the story of chorioamnionitis must end with delivery because otherwise that is a terrible medical story. And so I like to see how we all sort of start to get twitchy and start to get really agitated because we have this really physical response to a poorly told medical story. Now, there's a second type of story that I think we are truly embedded in, and that is this type of story that patients tell. And patients telling us a story, whether or not they are a child, an adolescent, or a parent telling the story of the patient, is an integral part of what we do. And I would tell you that it's not just an integral part of diagnosis, of figuring out what's going on, but it's part of the care that we provide is to help build that story. And that story guides care, it guides options, and it guides outcomes in a very concrete way. And I'm sorry, this is very female oriented because I work with largely female patients who refer to themselves as her. I clearly need to edit these slides. And ultimately, if you are doing a really good job, if you are doing a really good job with your patients, you are actually helping them tell their story in a way that makes a narrative that fits with their values and their goals. Sometimes for today, and sometimes really forever, because sometimes the decisions we make go forever. When that patient cannot or won't or isn't given the opportunity to tell their story, or when their story is told for them by somebody who doesn't share their values, in medicine, it means they lose very real, very concrete physical power over what's going to happen to them in their body. And so I'm going to read you the story of Annie, page 96. This is a story I think many of you will recognize from your NICU rotations. Some of us are calling it a baby. Some of us are calling it a fetus. Some of us are calling it, though we catch ourselves when we do. None of us feel good about any of this. We're all talking to Annie Riley, but really to her whole family. She's pregnant, 23 weeks and 0 days by our best estimates. Until yesterday, she was having a normal, uncomplicated pregnancy. Then yesterday, when she was running errands, her water broke. She came to see us, and while being evaluated, she became uncomfortable. Now she's in labor. We are trying to stop the labor, this complicated process by which our body works to eject the contents of the uterus. Our treatments for this situation are old and not terribly effective. Right now, it looks very much like she will be delivering within the next few hours or days. So we're in her room talking and talking and talking about the pregnancy, about the fetus, about the baby. Is it a baby? Or is it a fetus? That's the thing, really. That's the crux of the matter, because we need her to tell us. Here is her limited menu of options. Option A is the story of a miscarriage. In this story, the pregnancy is a fetus. It is under 24 weeks. I wrote this a little while ago. The rate of survival at this gestational age is very low. The infants that do survive are overwhelmingly affected by the sequelae of their extreme prematurity, possibly blindness, lung problems, cerebral palsy. The chance of getting a child out of this process is small. The chance of getting a healthy child is vanishingly small. If she chooses this story of miscarriage, we will allow the fetus to be born. We will not torture it with tubes and sharp stings. We will offer comfort care and make sure it is warm and place it on Annie's chest for as long as it stays in this world with us. Option B is the story of an extremely preterm birth. It is not a miscarriage. In story B, the pregnancy is a baby. A baby will be born, and we will fight for its life. We will place tubes and lines in its tiny translucent body. We will bring to bear all the wisdom, all the knowledge, all the science and computers, everything we have. It likely won't be enough. The baby might still die. The baby will probably still die. If it lives, it will probably be impaired, somewhere between moderately and severely so. Annie has to pick a story. We're all very insistent that she has to pick a story as soon as possible. Why? Because if it's story B, we'll start to do things to her, and some of those things are not very nice. We will give her strong medications to try to offer the baby some narrow advantage when it's born. We will strap her to the bed and vigilantly monitor the heart rate of the baby. We will swarm in and out of the room, touch her and examine her and poke her for blood tests. We will consider offering her an emergency cesarean delivery with all the risks entailed by urgent major abdominal surgery. The kind of cesarean delivery we will offer her will, by virtue of the anatomy available to us at 23 weeks, be a vertical uterine incision, which will compromise all of her future pregnancies and deliveries. We will do that even though, at the time that I wrote this, the chance of that baby leaving the operating room alive in my institution was less than 30%. But for story A, we wouldn't do any of that. We would not even listen to the fetal heart rate because we wouldn't do anything differently. We don't do surgery and risk a woman's health if it's not going to change an outcome. We will make the room quiet and peaceful. We will make sure she has one stable provider and a nurse who knows her and who is good at this. We will hang a picture of a leaf with a teardrop on the door so that all the members of the staff know that a loss is occurring in this room. When the delivery happens, we will give the family time. We will help them take pictures and start a memory box. We will mourn. Until Annie makes her choice, her providers are so very uncomfortable because what is good care in story A is malpractice in story B, and vice versa. How can we care for this patient until she tells us what care is? Now you're all asleep? Maybe. So I think that we have all had experiences where we are working with a patient to craft a story. The story sometimes is a dangerous story, because I think the most dangerous line in medicine is we did everything we could, right? And sometimes it's a story of we tried really hard and in the end we couldn't fight nature enough. And sometimes it's a story of we tried really hard and we won. And so much of what we do is craft that narrative. But I think the other thing that happens is that stories, like everything else that humans do, have a good side and a bad side. And one thing that happens is that we often create a narrative either between ourselves or between the patient and ourselves, and we get stuck. And there are examples of being stuck for tunnel vision and diagnoses. I would argue that implicit bias is a story that you've told yourself and you're stuck in it. You're stuck in your understanding who this person is and what their values are based on certain things you noted about them that are not true, like the color of their skin or their socioeconomic status or where they came from. And I think we get stuck in a way that can make it sometimes hard to get out. And sometimes the story itself is why we make mistakes. So this is the story of Nora. I will just say nothing bad happens in this story, but the pediatricians were very annoyed with me during this actual event. Nora Salmon had only one prenatal care visit with our hospital just this week when she was 35 weeks pregnant. She did have a first trimester labs done somewhere else. From her purse, she produced a wadded up purple pregnancy passport, which had a negative HIV test scribbled on her 12-week visit. But then she had a second HIV test done just last week on her first visit to my hospital. This is our protocol for patients in their third trimester, and Nora's third trimester HIV test was positive. Third trimester HIV is a risk for her, but also a risk for her baby. The baby can get the virus during labor and delivery and live with it its whole life, or we could prevent that right now. The initial HIV test we had at the time that we took care of Nora was a tricky one. It was known to be a false positive a large portion of the time. Back then, this false positive result was frequent enough that it didn't generate a full official report. What it did generate was a reflex test called a Western blot, a more precise protein assay to tell us whether the result was real or not. This story, by the way, I feel like tells you exactly how old I am. It's a long time ago. When Nora came into labor and delivery, her Western blot was still pending. It was in process on some anonymous countertop on some lab somewhere. But right now, there's a positive partial HIV test in our hands and a woman in labor in front of us. If Nora truly had uncontrolled HIV, our doctors could have offered her a cesarean to minimize transmission to the baby, which, to be honest, is what my NICU really wanted. But they've got that crumpled purple paper from first trimester, and Nora's very clear protestation that she has not had any new sexual partners since then, and that her partner hasn't either. Nora is 100% sure she doesn't have HIV. No, she's 1000% sure. The overnight team doesn't recommend a cesarean. Major surgery based on a probable false positive seems extreme, but they do want to do something that can offer the newborn protection from lifelong HIV. They start antiviral medications during labor. Antiviral HIV medications like zidovudine can prevent transmission to the neonate during labor and delivery. The plan is to stop the meds if a result returns negative. That's the plan. Morning comes and Nora is still pregnant. I join the team on the labor and delivery floor rounding on the high-risk patients. I check the computer. The Western blot has a result. It is, as we've all hoped, negative. Negative, I sing out. That's wonderful. But then I look closer. That result's been back since 3 a.m. Why is she still on the zidovudine? The team hems and haws. We just, the night team was busy and we wanted to discuss it. The day team wasn't quite sure. We wanted to talk it over. We wanted to be sure, And I do know. Once you have a label, it's very hard to let go of it. Once you have a story, it's very difficult to change to another narrative. Even if the story is false, even if you can point to digits on the computer and say, this is not true. Still, the absence of action, the not treating the patient, was too hard for a team that entered with one reality and exited with another, just wanting to do the right thing and not sure enough to know what the right thing was. The patient was already exposed to the risks of the medication, right? So what's another dose or two until we make sure that everyone agrees in the light of day that this is the new truth? Let's turn off the zidovudine, I say. Everybody laughs, but nobody moves. In the end, I have to write the order myself. I ask the nurse if she wants me to push the off button on the IV pump, and she tells me that now I'm being silly. Am I say? Once upon a time, there was a woman with HIV. She came to us to have a baby, and we kept that baby healthy by giving large doses of medications. We were heroes, and we won. That is a story, but is it this woman's story today? No. The story changed, but we kept rolling forward, handicapped by our medical narrative, by the story we told each other. We kept our sword out, chopping at a dragon who long ago left the building, or maybe never existed at all. If we get better at this, maybe we can figure that story out more accurately. Maybe we can figure out how to look at the dragons in our story. Are you the real enemy? Do we need to have this fight? So I think we've talked a little bit about how narrative is the way that we construct stories for each other, patient to doctor, doctor to doctor, medical providers to medical providers. It's also how we get stuck. But I think one of the most beautiful things about story is it's also necessary for us to move on. Narrative is redemptive and often the way forward. Sometimes I think that if we can find a way to craft a more nuanced story, that's actually the therapy that we provide for our patients. We allow people to feel seen. And I think it actually is a true path to recovery for many of our patients. And so this last story is a story that I think is about a time that we were able to change the patient's story to allow her what she needed. This is another day, another labor floor. Nadia Triggs is sad. She has known this day was coming. For the most part, she chose it. She is laboring away in a labor room in the corner, in comfort and in quiet, since her epidural was placed several hours ago. Nadia is sad because there's something so deeply wrong with her fetus, wrong in a way that it means it will not live long with us. When we see the fetus on ultrasound, we can see right away the bell-shaped curve of the chest, tighter than the abdomen, the heart taking up a huge portion of a too small thoracic cavity, the bone shaped in a curved embrace, too tight, no room for lungs to develop, and so none have. The fetus is doing all right for now in its small fish-like space where oxygen comes from the umbilical cord, where it doesn't need lungs. But when it gets out here to us, it will need to breathe air through the mouth and nose and through the lungs it does not have. And so we have told her the baby will die. This is the account Nadia was told by one wise woman and then another wise man, as we all struggled to understand what we saw inside her. It's a story I read in her record. It's a story she told me when she came into the hospital to have her labor started. She had already decided with those wise doctors that her labor would be one during which we would not monitor the fetus, since if it showed distress, none of us were willing to perform a cesarean delivery to deliver a baby that would not live, no matter how quickly and well we would act. Better not to look, the story goes. Like many ancient stories before, you turn to salt or worse. But Nadia, laboring away in comfort and in quiet, now wants to look. She calls and asks to speak to me, and when I come in, she says, "Can I listen to the baby's heart?" Her nurse stands by, uncomfortable. This was not the plan. And I say, well, yes, of course, but can I remind you the story we told each other? We talked about how if we watch the fetal heart rate go up and down and then go down and down and down and down, it's hard. That feels risky, because my training and the nurse's training and all of our training is to rush you to the operating room and get the baby out. But I say gently, getting the baby out, that's not relevant here. I wish it were different, but there's no surgery I can do, no matter how fast or how well, I can save this baby. And to watch the heart rate go down and down and down, that's hard on you and hard on all the people taking care of you who have trained all their lives to prevent this. You might even foolishly forget who you are and do what we always do. Risk to you, no good reason, etc., etc. I know all that, Nadia says. But it's just, I want to know if the baby is dead inside of me. I know we won't do anything different. I just want to know. And I understand, finally. Inside this nightmare that she didn't know could exist of a malformed fetus who can breathe like a fish, but not like a human, there is a worse nightmare. It's the nightmare of delivering a dead baby. And inside that nightmare is an even worse one, delivering a baby and not knowing if it is dead. We are 3 levels deep in a story she does not want to live in. And I can take her 1 level back. She could live in just 2 nightmares. I say, what would you like? What if we checked every 20 minutes, just a brief check, a few times every hour? Would that work? We can do that. Yes, Nadia says and sighs with relief. That is what I want. We check every 20 minutes. There is always a heart rate, low but normal in the 120s. I will never know if there was distress during the labor, but the baby is born a few hours later, alive. My pediatrics team is there. They assess the baby briefly, and there's not much they can do. They give the baby to the mother to have on her chest, to be with each other for as long as they have together. Somebody once told me that it's diagnostic for becoming MFM if you cry easily. So pathognomonic in my case. So I think narrative is how we move on for the patient. Crafting a narrative that they can live with, remembering that we're helping them craft a narrative they have to live with today, but maybe also forever. This is a story of how I am a parent. This is a story of how I dealt with adversity. This is the story of how I unconditionally love my child, even if that love looks different in different days. This is the story sometimes we tell ourselves. We have a patient who goes through something terrible, and sometimes I have to remind myself that this might be the middle of their story. Maybe I'll see them in a year or 2 years, victorious, in a different kind of life, but happy, healthy, as healthy as they can be. I think it also helps us, and that's a whole other lecture, fight bias. We can tell stories that help people be the people they are in the fullness of their nuance. Both helps us fight diagnostic bias, to remember that just because she came in with an HIV label doesn't mean she has to always have it. Helps us fight cognitive bias, helps us fight the bias we don't always know we have, that this person will want this thing because I think that this person has these values or these characteristics, and allows us to understand them in the fullness of who they are, because people are complicated. So in conclusion, I think you guys are all already writing. I think we all are every day. We're telling stories. We need it to do the work that we do. We need it to work to each other, and we need it to assist patients in telling their own stories. Narrative has a downside. You can get stuck, and getting stuck when you are a physician in a narrative can be dangerous for your patients and sometimes for yourself. But crafting the right narrative, working with your patient for a narrative that reflects their values, can be redemptive and therapeutic, and some of the most important work that we do. And I think noticing how good you guys already are at this and valuing it is important. And I would also argue that it means that writing is something that you can do in your medical career. It's a good match. You already have the skill set. The things you have to say and show the world are important, and they need to hear it. And that writing careers, at least mine, is not straightforward, as nothing almost ever is in human life, and still worth doing. And that's all I have for you today. I put my website up just because it's an easy way to reach me, and I do write back. I'm totally happy to take questions if there are any.
Thank you so much, Dr. Karkowski. This was excellent. Yeah, I'll open up if there are any questions either in the chat or if anybody wants to unmute. Dr. Perrin, I know you have your hand up. You want to go ahead and unmute and ask your question?
Sure. This was extraordinary. You kept asking, are we asleep? And no, I'm like on the edge of my seat, riveted. The stories are beautiful. Your insights are extraordinary. I just want to thank you so much for just a wonderful, wonderful grand rounds. I did have a couple of questions. I've done some writing myself, and very little of it is published, but you're inspiring me to do better with that. When I've done the most writing, it's actually been for me as catharsis, and was actually during my training when I was having the hardest time grappling with what I was seeing in medicine as a very young doctor, sort of in the dark. And I wondered how much this helps you. You talk about the stories that need to be told for the patients, and that's extremely admirable, but I'm also curious as to the effect it's had on you. And then the other question is somewhat unrelated, but it speaks to your idea of the soap note as a, as a story, and the way that we tell stories in medicine is not the way that other people tell stories. And now that patients are reading their own charts, which is something that I have written about, I'm curious as to how you think that disconnect works for the patients who are reading our stories.
So I think this understanding of medical narrative, it's true that it has varied functions in many of our lives. So for example, at my institution, the medical narrative program is really one about medical students processing. They're using journaling in its way as a form of meditation or self-care. And I will tell you that I have never been good at that. I am terrible at journaling, and I seem to be very uninterested in writing unless I have an audience, which often makes me feel shallow, but there it is. I think the other thing is, so I think writing can do all those things, right? The question is, what does it do for you, or what do you want it to do? And to be honest, the same experience can be mined multiple times. You process it, and maybe you write something for medical press. Maybe you write something that's advocacy, right? Hey, humans out there, do you know what you're doing to my patients? And maybe you write something that also is just poetry. So I think the truth is that medical narrative can do all of those things. And the skill set for all those things is very similar. So I basically feel that you can go any of those places. But I do think many people use it for their own processing, and I think that's really beautiful. And I see it more and more as part of medical curriculum as a way to handle, I think, this transition to being a medical provider, which I think is shocking for many of us, like deep in our bones. You mentioned about the EHRs. I have to tell you, I had this recent experience where my nephew was admitted urgently while on vacation to a hospital, and my sister-in-law, who's a second grade teacher, she found the notes so lovely. And it's so funny because many of the things she found so lovely were things that are very generic for us. This is a well-nourished child in no acute distress. And I think the fact that the parents were called lovely. And I was like, you are lovely, but also they mean that you're non-compatible. That's what we really mean by that. So I think it's been really interesting. She had tremendous appreciation for the note. And I was like, that's actually lovely, because how much of our time do we spend writing notes, catching up on notes? Notes are a huge part of the work that we do. We put a lot of care into them. I've also had patients reach out to me and be like, that's not what happened, or that's not what I said. And that's really hard. And I think we're all changing our language to be more hedged, which in some ways is a shame, in some ways had to happen. I think ultimately having patients have access to the EHR means that it's more of a document that we write from two perspectives, and that's probably a good thing, but it's a new way of writing for us, and so it's hard. Somebody else asked, how do I see EHRs influencing narrative? And I don't know, I have to tell you, for me, when I started fellowship, we were still writing notes by hand, and that was just like absolute drudgery. Like I am terrible at handwriting notes, and my notes are illegible. Actually, when I was in Israel, they told me that my handwritten notes were not legal, like not legal tender. I had to, and I don't know how to type in Hebrew, so it got very complicated for a while there. So I find that EHRs mean that I'm actually much more loquacious. I write a lot more. I say a lot more. I document more of our conversation and the nuances. I also think for many people it's a smart phrase, and your counseling sounds very repetitive, and does it really reflect what you did? A lot of the work I do in quality actually is talking about how your note can say what you did. It can also remind you what to do, right? So when I make a smart phrase for third trimester labs, it's because I'm reminding you what the right labs to order are. And when you put that in your note, you're making a promise that you're about to order them. So there's also a way of writing is aspirational in the EHR and can help us get there. We always have to make sure it's true. Maybe not on the emotional level, but definitely on the I ordered her syphilis test level.
Yeah, Dr. Kane.
Sorry, I couldn't find my hand raised via Zoom. Thank you so much, Javi, for this. I was wondering if I know that in addition to writing, you've also done public storytelling. And I was wondering if you could tell us a little bit about those experiences and how that plays into sort of your sense of the written word and communication about medical narratives.
I've only done a couple of things, and I have to say, I think what it is tremendously validating, because if you tell a story about, I don't know, like we were talking about a healthy 8-year-old who's now in the PICU with the flu, it is a story that you tell every day. And it's a hard story, but you're also very focused on the, how can I get her better? What do we do tomorrow? Did somebody write her note? And telling that story to lay people is phenomenal because it validates why you do all those things. That all those things are a puzzle piece for something that's so much more important, which is that you are going to get this 8-year-old home to her. I don't know, there's something really validating about watching that emotion of that hit in real time. I highly encourage, it's a really lovely thing. It's an in-person thing, so it's a rare thing these days. I hope we're getting back to it. That answer you? I see a hand up from Dr. Lipkin, I think.
Yes, thank you. So over the years, I found writing notes, I use the word drudgery for sure, and burdensome, and taking away from the work that you really want to do and from your personal time. So I shifted my thinking a while ago, favorably, I thought, towards thinking of my notes as pure documentation, sort of more of a surgeon's perspective on note writing. You just got to document something, and so they ended up being briefer. I think I still have some narrative in there, but how can one reconcile a brevity with providing the kind of narrative that's necessary in a medical note, do you think?
I mean, I think you're probably still doing the job, right? People don't read your notes and say, what is he doing with this patient today? They know what you're doing with this patient today, right? So your narrative is, maybe it's a haiku instead of a sonnet. You're saying CT negative, complete antibiotics, DC home. My argument is that that's still a story. It's a story of a patient who doesn't need to go to the OR. I'm so happy for her. So I would say that you might not be documenting every tearful exchange. I don't think that that's what a medical note is about. My argument is still that that's still a story. Maybe you're Hemingway and not more
I'm not a Russian novelist, right?
You're not a Russian novelist, but it's okay. Hemingway still, those are great stories. They're maybe greater because there's less there. And I mean, it's doing the job, right? So when you're doing the job, you're telling a story and you're usually telling a really consistent one without even realizing it. But it took us all, I don't know, 10 to 12 years to do this properly because it's hard. We're not all doing it because it's easy. We're all doing it because it's really hard and we put a lot of time into it. You are still successfully telling a story because those notes work, right? The person who covers the next day knows what you were going to do. So they're successful and I would never feel bad about that. It's a different style.
Thank you.
Great. Well, thank you so much for coming. This was amazing. And if there's any last questions or anything anybody wants to ask, but appreciate you all coming. I hope everybody has a lovely holiday. Dr. Moon, did you want to say something?
I just want to say thank you. That was fascinating and inspiring and thought-provoking and all those good things. So plenty of good stuff to think about over the holiday and a lot to be thankful for. So I'm really glad you offered us this.
Thank you. It's always a little bit of a scary grand rounds to give because it's not about medicine. Particularly, I'm not going to talk about hypothyroidism today. I do, yeah. If anybody ever wants to talk about sort of just like soup to nuts and bolts, how do I pitch? Who do I pitch to? Those are really good things to know. And that's also sometimes things I'm happy to talk about individually or do a workshop on.
Oh, that would be fun. Great.
Awesome.
The workshop idea sounds great. I know there's a lot of people who would be interested.
And
Especially if you're
often
successful.
people have a real interest in sort of memoirist writing, which is tremendously valuable, or also op-ed advocacy writing, which I think many of you feel really strongly drawn to for very, very good reasons right now.
Yeah, great.
Please feel free to email me. It may take me a few days to get back to you. Just a little swamped clinically right now, as Dr. Kane can know, as I took some calls from L&D last night, but I will eventually get back to you, I promise.
Thank you.
Thank you so much. Thank you, everyone.